So David George is a global leader in breast imaging for 25 years. He's driven the market growth of early breast cancer detection products, and he has held a senior role at Transworld, LORAD, Hologic, R2, Supersonic, Imagine, IVU and U Systems, who were acquired by GE. So please welcome to the stage David George from the USA, all the way from the USA, who is the President North America for Corning Corporation. Please welcome David.
Very much. Am I coming through?
There he is. There we go. A nice surprise. Nice to welcome you, David. How are you?
I'm very well, thank you, and thank you very much for having me today.
You're very welcome. Over to you, darling.
Good, thank you. Are my slides being presented currently?
No.
Can I do it for him?
I can manage it if you're projecting it.
We're projecting. If you want a screen share, that'd be a lot easier.
Yes.
Thank you.
Give me a moment. I'm going to redo the screen share. Are we on now? Is my slide presenting?
We don't have them here, so.
Well, let's see.
Yes. We're in.
Better now?
Yes.
Okay, thank you very much.
Thank you.
Sorry about the slight delay. Little technical challenges sometimes between our two distances. Well, again, thank you for having me today. It's an honor to present the Corning innovative breast CT device. And my goal is to briefly describe the process of breast CT and to express the many benefits of our innovative and long-awaited improvement when compared to the current standard of care, which I have tremendous respect for. As indicated in my introduction, I have actually been in the world of breast imaging for over 38 years. I've been with Corning for 10 years during some of the early development and regulatory processes. And my job is, aside from my executive duties, is to manage the commercialization of the product, our contracting, our distribution, our sales. Now, breast CT also provides some new efficiencies and some patient management processes that are not available today. Number one is the patient and the patient image is going to present in a very normal and natural presentation as opposed to compressing the breast. That means there's no deformation from compression. The doctor has the ability to look at slices from nipple to chest wall in every direction and to adjust slice thicknesses. This is very representative of what we have learned to do in body and neuro CT imaging. When you have this capability, you are presented with a new way of examining the breast tissue. And it also eliminates a very common problem in two-dimensional imaging, not just in breast, but in all two-dimensional imaging, and that is overlapping structures hiding small cancers. We are obviously presenting in full 3D display, and of particular note, I will mention that in mammography today, if the positioning isn't just right, we go back and try it again, we adjust our technique, we re-examine the patient, and in the case of breast CT, there is no need for retakes, there is no poor positioning, or even a request for additional views to clarify an area of interest. Everything is in that isotropic data set. This is a major improvement over the current standard of care. Now, if we look at this animation, if the video is going to work for me this morning, what happens is the patient gets on the table, they simply lower themselves on the table, they put one breast through the aperture, they lay for 7 seconds, and then we switch to the contralateral side and do that breast with another 7-second rotation. So then now the movie decided to play for me. So this is giving you a little idea of how the acquisition is made. So very, very similar to CT imaging, with the exception that we are only using radiation on the breast. There's no radiation to the lung field or cardiac field. And we think that's another major advantage. By comparison to mammographic views, here's the diagnostic mammogram. As you see, the standard 2-view mammogram, the right and the left, the CC and the MLO view. And the patient needed some additional clarity, so there were multiple images taken, which equates to multiple compressions, multiple doses in order to complete this particular exam. If we were to take that patient and put them on breast CT, this would have been 1 7-second scan of the breast. We would be able to have the same findings and the same outcome as that mammographic series that I just showed you. There's another example of looking at it in multiple planes and also seeing the area of interest and co-registering that in each one of those planes, so we increase our confidence of what we're seeing. Here's another example. What we're looking at is another exam that required multiple views to bring clarity to the radiology reader. And if we use the same idea of putting the patient on breast CT, you're looking at 1 7-second scan, understanding the entire condition of the tissue, and also looking at it in 3D in the bottom right-hand corner, which we are able to run slices through from beginning to end or front to back on each of these planes, as well as rotate that 3-dimensional image to any angle that the radiologist could use to be helpful. Here's another one. This is a difficult case we see often in breast imaging. We're looking at some spot compressed magnified views to help clear an area that we were concerned about, and as it turned out, it was invasive lobular carcinoma. But the patient went for an MRI. And when the MRI scan took place utilizing the gadolinium contrast medium, not only did we find the primary lesion, but there was a secondary lesion that showed up on MRI, which certainly expresses the value of MRI in breast cancer detection. Now, if we took that same patient as we did and put them into breast CT, and we used breast CT contrast, which is the same contrast used to identify lesions in head, chest, and abdominal CT, which is an iodinated contrast solution, water-soluble, very tolerable, very safe for the patient. It's proven over the last 40 years to be very safe. But look at the enhancement that we see both in the primary and the secondary lesion. And this was all done within about 10 minutes to do a pre and a post-scan environment. So what we're seeing here is another advance from the current paradigm. One more example is this particular image that we are looking at, a standard 2 view. We see the enhancement. We go to contrast. Now I'm showing you these because the first set of images to the left are the non-contrast images. You still see the calcifications. You still see the region of interest, the lesion. But when we use contrast, the lesion is enhanced. The uptake of the iodinated contrast is very clear to see, and you can see the associated calcium. Calcium in mammography is used as an indicator that there may be an area that should be reviewed. Here you're able to see the calcium and the enhancement. Now, a little side note, calcium is an important indicator in X-ray acquisitions of breast tissue, but it is not visible on MRI. So when we see breast CT with calcium and enhancement, it helps us with our specificity, even greater than what we see in MRI. Now, the breast CT from Coney is a multifunction device, not just a scanning device. We can do the diagnostic workup, which is I shared in those series of images that I just illustrated. We can do post-operative monitoring to understand how the patient is doing after the surgery, identify if there were any multifoci disease or contralateral disease. We can do 3D guided biopsies. You can use this device with contrast to supplant the MRI when neoadjuvant therapy monitoring is necessary. It is an excellent platform to do small, dense breasts, which are very problematic in the mammographic side of the imaging paradigm. Implant evaluation is extraordinary. I'm going to show you an image here very quickly about how we image implants by comparison to today's standard. Contrast enhancement and, of course, density measurement are all part of the package that comes with a Coney breast CT device. Now, when we think about performing X-ray guided needle biopsies, a very common process, we think that breast CT biopsy is a very, very good alternative to stereotactic biopsy, which is used today. However, when we do breast CT biopsy, we are reducing the dose rate to the patient by over 50%. We're using 3D guidance to target that lesion versus Cartesian or polar coordinates, which is basic triangulation used in stereotactic. The procedure time is very quick. It's approximately 15 minutes, and biopsies can be done with or without contrast based on the radiologist per view. And of equal importance, when you put the patient into the breast CT performing a biopsy, the images are 100% reproducible from the original image that was used to identify the area of interest. So this is a photograph of the biopsy device with the grid in place. That is dropped into the aperture, and here we have another photo to the right of the patient in position. The table elevates to approximately 150 cm above the finished floor, and the doctor can get underneath the table with a stool and his associate to harvest the samples. This is the way the imaging is done. So we actually take an image, we measure the distance from the grid to the area of interest, the obturator is put in place, and then we harvest the samples and move on. The other function I mentioned earlier, which was small breast imaging, this is a very good example. We have a very small breast, very dense breast. It's difficult for a mammography technologist to pull enough tissue into the field of view because simply it just doesn't exist. It's very difficult to manipulate that breast tissue and get it into the field of view, as illustrated on the CC view to the left. And the MLO to the right, we're picking up a little bit of pectoral muscle and just a tiny bit of the axillary tail. If we use that same patient and put them in breast CT, we see a very big adjustment in how we're able to identify any of the areas of interest within the small breast. If you'll notice, we actually get far enough back that we can see rib, which is an indicator that all of the pectoral muscle is being properly imaged. So the female population with small breast will find this very, very advantageous. Now, I mentioned neoadjuvant therapy monitoring. I wanted to show you a little bit of how that works, becoming very popular over the last 20 years to track the shrinkage of a tumor prior to surgery. So we feel that we use breast CT with contrast to do this as an alternative to MRI. It's a fairly rapid 10-minute exam versus perhaps 30 minutes or 35 minutes on MR. And we measure 3D volume at each one of the phases. So this is an image showing the 3D volume is 61.8 cc's. And as we continue the monitoring month over month, we watch and measure the shrinkage until it has gone to the lowest level it possibly will get to, and then we can intervene with surgery. Very fast, very efficient, and the use of iodinated contrast material instead of gadolinium, which I think is an upside for most patients. This is we talked about implants, and this is, I think, a very interesting component of breast CT. You look at an implant today, if we were looking at the mammographic image of this particular patient, we would see one image compressed with the implant in view. And then the technologist is trained to push the implant against the chest wall and then compress the remaining tissue between the compression plates so we can interrogate if there's anything in the tissue that is in need of workup. But with 1 7-second non-compressed view, we're looking at the implant from multiple angles. You can obviously see and be able to judge the structural integrity of the implant. In this case, this is a saline implant, so we can visualize the valve and understand its particular condition. Very, very fast and a very appropriate method for implant imaging. Now, effectiveness. I usually have this conversation with radiologists and physicists about how effective is breast CT by comparison to the current mammographic imaging. Well, this was a study that was done that produced sensitivity, specificity, and accuracy by comparison to mammographic imaging on 400 cases. And as you can see, breast CT rated very high, considerably higher than mammography. And we had only claimed equivalency during our FDA clearance, but what we have learned is we are not just equivalent, we are many, many times superior to a mammographic image. And again, that goes back to my earlier statement about the utilization of an isotropic data set so we can see the areas of interest from multiple angles. When we talk about the effectiveness of contrast-enhanced breast CT, we have to compare that with the gold standard of MRI. So we know MRI uses gadolinium and breast CT uses iodinated contrast, but if we study the two comparisons to each other, we learn that the sensitivity of breast CT with contrast is on par with breast MRI with gadolinium, and the cancer detection rate is also on par. But it's interesting to note that the specificity, which is oftentimes what radiologists are concerned about with MRI imaging, is that it shows so much, the sensitivity is so high that there are many false positives and false negatives that come from an MRI exam. But if we looked at the breast CT comparisons, we're significantly greater in specificity. And we also have the ability, as I mentioned before, to visualize calcium around those enhanced areas, which is beneficial to the radiologist. So overall, if we look at efficiency, there's multiple views in mammography. It can take anywhere from 15 to 30 minutes or an hour if it's a complex case. In MRI, they're long exam times. It's relatively uncomfortable. It's a loud environment. We're using gadolinium contrast media. It's complex and time-consuming to interpret those imaging outcomes. And there's also significant contraindications to MRI of the breast, including patients with claustrophobia or metal implantable devices, and also those that have gadolinium concerns. If we were to convert to breast CT, we would be in an environment where we'd be doing one single scan in 7 seconds or a 10-minute scan with the use of contrast. It's very comfortable. We don't use compression. It's more accurate than a mammogram. When contrast is used, it's at least as accurate as MRI. And there's very short interpretation times of a breast CT data set when you compare it to MRI. Of particular interest to coding was during our FDA clearance, we had the FDA sent out a publication talking about this new innovative technology. And these were some of the comments that I extracted from that publication. And the one that I think I like the best is from Dr. Kyle Myers, who's an optical scientist sitting on the committee. And he said, "We get a unique view of the breast like never before and evaluate its structures. It's almost like seeing the anatomy itself." Highly unusual statement from a group of committee members at the FDA. I also wanted to point out that there has been a significant body of research and publications and peer-reviewed publications on the science of breast CT. We have over 160 peer-reviewed publications. All are available for review, and we're very proud of the work that went into this prior to our commercialization efforts approximately 18 months ago. So we are very proud of the device. I hope that my brief explanation gave you some insight into where we think the next paradigm in breast imaging is going. And having said that, I will turn the program back over to the folks here. And thank you very much for having me at the meeting today. Much appreciated.